Hello class, this is the lecture for the soft tissue neck exam. So if you refer back to your chest chapter in Bontrager, you'll see the parts of the respiratory system, and we're talking about the upper respiratory system or the soft tissue neck. Now you see that you have the pharynx, which serves as the passageway for food and fluids as well as air, making it the common passageway for digestive juices and also the respiratory system. Now the pharynx is broken down further into the nasopharynx, which is the most superior aspect, the oropharynx, and the laryngopharynx or hypopharynx. You then have the hard and soft palate, which make up the roof of the oral cavity, separating the nasal cavity above the mouth from below. The lower posterior aspect of the soft palate is called the uvula, and that marks the boundary between the nasopharynx and the oropharynx. The oropharynx is found posterior to the mouth, with the tongue creating the anterior wall of the oropharynx. Now, an additional structure that you're going to have is the hyoid bone, and the hyoid bone acts as the foundation or the base of where the posterior aspect of the tongue attaches itself. You'll also note that you have the thyroid cartilage, which is also known as your Adam's apple, and that's at the level of C4, C5. Posterior to the trachea, you have the esophagus. So here is just an x-ray of an AP soft tissue neck, and it's just showing you that anatomy that we talked about. You see the hyoid bone on the right-hand side pointed out there. You see on the right-handed radiograph the oropharynx and the nasopharynx are going to be the two superior black lines just above where it says normal epiglottis is thin. And then you'll note that the trachea sits anterior to the esophagus. Once again, here's a lateral projection. You see the outline of the soft palate, the base of the tongue, and how it sits just superior to the hyoid bone, which is in profile there. You have the oropharynx coming down, then you have the larynx, you have the thyroid cartilage, which is about at the level of C4, C5. You see the trachea and the esophagus, and then obviously posterior to that soft tissue structures is going to be your cervical spine. So there's basically two projections for the soft tissue neck. So for the AP, we are going to have the patient erect if possible. You're going to be using a 40-inch SID. Your center ray is going to be at the level of C4, C5 with a perpendicular beam. And you want your AML to be perpendicular to your IR. Now the AML stands for the acanthomeatal line. And what that is an imaginary line that you're going to draw right below the nose and above the top lip. So that area where mustaches are grown is known as the acanthomeatal line, or AML, and that you draw a line from that area between the nose and the mouth to the EAM, which is the external auditory meatus, or the opening of your ear. So you're going to draw an imaginary line, and what this does is this basically just lifts the chin up out of superimposition over your soft tissue neck structures. So you want to make sure that your chin is up so that your AML is perpendicular to the IR. That's going to unsuperimpose your structures so that you can see as much of the upper soft tissue neck as possible. You want to collimate side to side, make sure that your marker is in the light field, and you also want to have your light field open to include just around the EAM or above the EAM down through about T1, T2 area. Now you're going to tell your patient to take in a slow, deep inspiration during your exposure, and that helps to fill the trachea with air so that we can see it as well as possible. Now the reason why we take these soft tissue neck pictures is typically because of possible foreign body obstruction, or if there has been some sort of traumatic injury or swelling to the soft tissue of the neck. So they would look to see if a fish bone or a chicken bone or a pill was lodged in the patient's throat if they could not swallow it down and it was stuck in their airway, or if there was some sort of respiratory or viral infection or swelling of the soft tissue neck. Here is the lateral projection. So the patient's still going to be standing erect. We're looking at that image on the left-hand side here. We're not going to look at the image on the right-hand side, just the left-hand side. So you're still going to be at the level of about C4, C5. Make sure that you have light, as it's indicated on this picture, above the level of the EAM. You're now going to pull the SID back to a 72-inch SID to overcome the OID, or object to image distance, to the IR. You're going to have the patient thrust or kind of stick their chin out once again to get it out away from the soft tissue of the neck. You're going to have the patient take in a slow, deep inspiration during exposure once again. And please note that you don't see it on this picture of this gentleman being exposed, but you do need to have the light field covering the nasal passage. So we want to make sure that we can see the soft tissue of the nose on your Walbucky so that it can be visible on your radiograph. That's the way the radiologists at your clinical sites want to see it. Now, when you're looking at your evaluation criteria, you should see an air-filled trachea and larynx. You should see the shoulders not superimposing over the trachea, as well as your chin and your mandible not superimposing as much of the structures as possible. You want your collimation open so that you're still going to see the nasal passage, because they want to see the entire nasopharynx, oropharynx, laryngopharynx down to the trachea. And you're just going to be seeing the soft tissue neck. So typically you can center about ½ an inch to an inch in front of the EAM or in front of the ear, because we're not concerned with the hard anatomy of the cervical spine. So this is just demonstrating that there is a foreign body lodged within that airway there. So that fine white line traveling down, it should just be filled with air or be black within the nasopharynx and the oropharynx, and you can see that there's something white in there other than just the hyoid bone. So that is a foreign body lodged in, probably a chicken bone or a fish bone that got stuck within the soft tissue. And then soft tissue necks are usually done, as I said, with people who have possibly swallowed a chicken bone or a fish bone or got a medicine pill stuck. But another common reason to do the soft tissue neck is for pediatric patients, and particularly looking for croup. So this is a viral infection that causes swelling of the soft tissue around the neck, and it's highly likely in pediatric patients over adult patients. They're going to come in with a barking sound, and some people say that they sound like a seal barking, and that is an indication of croup. So the picture on the left-hand side is showing you the steeple sign, and that narrowing or that steeple sign is an indication that the patient has that swelling around their passageway. So that is a finding from croup.